Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
That's right, folks. El Presidente of the Home Healthcare section of the American Physical Therapy Association, Dee Kornetti, is on the Senior Rehab Podcast. I'm excited for you all to meet her. She's quite the woman. She is a visionary for our field, especially in home health. She has lots of experience, about 30 years as a PT, and she's mainly in a managerial leadership consulting role now and is a true visionary, for home health. She has a lot to say, a lot of opinions that kind of go against what we see in home health today, and she's a game changer. So I'm really excited for you to hear her perspective and what she plans to do with her term as the home health section president. So without further ado, Dee Kornetti. Dee Kornetti, El Presidente of the Home Health Care section of the APTA. Welcome to the Senior Rehab Podcast.
Thanks, Dustin. It's nice to be here.
Yes, I'm excited to talk with you. We met at CSM, which was a pleasure. We had a good time and had lots of great discussions with a few other physical therapists. I'm familiar with your story, but let's share with the audience kind of your background in terms of your physical therapy career.
Sure. Actually, I've been a physical therapist. Maybe one of the oldest ones that you've talked to as far as in clinical practice for just about 30, 31 years now.
Wow.
And I've spent the majority of those in home health, almost 20 of those in home health. Up until the last year, I had co-owned and run my own Medicare certified home health agency in Central Florida. And I had that for about 11 years. And have been very active in the home health section of the APTA, well, the APTA in general, since I graduated back in 1985, but really became much more active around 2002, 2003, and really got involved in the home health section, leadership and volunteerism through the publications committee, starting up and helping get off the ground the practice committee and some of the resources that are out there, helping formulate the idea behind the education committee that's really kind of expanded our section. And just these past couple of years, I've been involved as the section program chair for the home health section for combined sections programming, and recently was elected president. And so I'm the new incoming president for the current 3-year term for the home health section. So I'm real excited. But the reason why I got that involved in the association is as a private agency owner, my own practice owner, I was looking for resources. When you're head cook and bottle washer, a lot of times what you really need to do is you seek out those other people, those other resources in the area. Yeah. And I found tremendous amount of resources. And I like to think that I helped move forward and bring along to other people tremendous amount of resources in the section over these last 10 or 11 years. And they were indispensable to me because there really is nowhere else for me to go as a physical therapist in home health to get basically the straight and skinny on what's going on and what is the right thing to do. Yeah. And the side effect of that, I wasn't seeking it out, but what I really got out of that, and really have gotten much more out of it than I've given back, has been the collegial relationships and the friendships. And now one of my current business partners, Cindy Kraft, who was the previous president for the section and has been a consultant for a number of years. We are now currently in business with Sherry Teague through Kornetti and Kraft and do consulting all over the country for home health specific content. So it's really kind of given me a lot more back, and it's nice to be able to pick up the phone. When you practice in a home health setting, and you have a little bit more, you're a little bit more secluded from a lot of other people.
Yes.
To be able to pick up the phone and say, hey, what's going on here? Are you seeing this? What would I do in this situation? And have good, reliable, expert people on the other end that either are going through it or understand it. And can help you, can help direct you, can help answer your questions, can put you in touch with the people or the information you need. So it's been a really good experience. And then I get to meet people like you, the young whippersnappers coming into the field.
I like it.
And it's nice. It's nice to see that all these other people are really embracing home health, because we all believe, and I believe for a long time, that it's the setting of choice for most of our patients.
Yeah, I would agree, and I just want to thank you publicly for what you're doing, you and Cindy for sure. I mean, many other people, because I'm relatively new to the field, so I really don't have a perspective at all in terms of the history of home health and just kind of the work that you all have been doing for years. And so I appreciate it, because it is. It is very challenging to be out and about, to be in someone's home. You have no freaking clue what you're doing. And a lot of times there isn't someone readily available to ask a question or, just to get their feedback. But that is changing, with the help of people like you and also just a lot of the people interacting on the internet and Twitter and whatnot. So it's exciting. What are some of the biggest changes that you've seen in home health just over the past 20 to 30 years that have improved just kind of our setting?
Unfortunately, I'd like to think that it was driven by the profession, but a lot of it has been driven by regulatory demands, good, bad, or indifferent.
Yeah.
And I think a lot of it has been to force us more into quantifying impairments and objective measure.
Yeah.
And that has been a requirement of regulatory guidelines over the last 3 or 4 years that we've really had to be much more attentive to documenting defensively. I think shining the light on the maintenance component to the post-acute care models and settings is critical, especially when you're dealing with people. Especially, I don't know about you, Dustin, but I think most of us, if we're not working in a specialty niche practice like pediatrics, we're dealing with older adults who want to stay in their own home. And so a lot of times these people have 2 and 3 or more chronic comorbidities that really are not something we're going to get better, but something that we can lend our skills to as therapists to help them prevent from getting worse or slow the natural occurring deterioration or decline associated with that disease process. So there's 2 things. And the third one is technology. Technology is making a world of difference. And I'm not talking about some of those traditional models like telehealth, which is great. What I'm talking about is the fact that we can get into a lot of our older adults' iPhones and their computers, and we can bring them individualized, patient-centered exercise programs. We can prescribe and dose them a little bit more accurately. And I think that technology has yet to be realized as much as I think it is capable of being realized. And just yesterday, someone that I did some of my work towards my PhD, which I didn't finish, but I did a good amount of studies towards my PhD at the University of Florida. And one of the individuals that I was coming into the program and she was leaving, Dr. Cheryl Flynn, has actually started a software company that focuses on cognitive assessment and training and physical assessment and training. And she works out of this USC Innovation Labs, and she's contacting me about getting this out to the industry and using these tools and being able to monitor metrics on these people and look at fall risk and look at their ability to complete executive functioning, and if these skills are being maintained through the course of time that we're seeing them for therapy or potentially being improved, all using a sort of an online gaming mentality.
Yeah.
And then I talked to someone like Jason Falvey, who is doing things out of Colorado University and has anecdotal information that he's finding about early identification of UTIs in older adults based on their Fitbit recordings or their readings and the fact that they're taking less steps. And he's starting to find that these are some of the earliest precursors to identifying, potentially a urinary tract infection or maybe even upper respiratory.
Yeah.
So you take those three things and then you throw in the things like the X factor, which is the younger clinicians, where home care has always been seen as one of those places where, or people believe it's one of those places where therapists go, out to pasture.
Right.
And it's the last practice setting, where things aren't hard. And in fact, it's extremely challenging. And I see that a lot more younger, doctoral level trained graduates are coming into this field and realizing that, not to take your phrase, but geriatrics can be very sexy.
Yes.
And when you have to walk into someone's house with a plan, you'd like to believe it's the plan that's going to work, but until you open that door and you see what's going on and the condition that person is in, you don't know that that's the plan you're going to carry out that day. So the level of creativity, the level of, I like to call us the MacGyvers of physical therapy, because we can go in with some TheraBand, some Theraputty, maybe a couple weights, a foam pad, and the things that we can accomplish to keep older adults safe and in their home is literally magical. I like to consider that's the magic that I bring into the house every day. Yeah. And so I think all those things rolled up into one, plus the changing of the payment structure and looking at the Impact Act and where we're going with post-acute continuum, that 2 or 3 years, home care is going to be the best place to be, because we know it's can be much more cost effective than any inpatient setting. Yeah. And we can control rehospitalizations, which is one of the biggest drives in our Medicare population, as well as some of the 24/7 staffed sites, such as skilled nursing facilities. And so, we're positioning ourselves with the technology, the expertise, the young blood, and the fact that we're being challenged to document, to quantify our impairments, to be experts in tests and measures, to pull the right tools out of our toolbox, and then still, besides the science of physical therapy, still bring that art with that MacGyver piece that we have to adapt, modify, overcome some of the things we face in individual houses every day.
Boom. Give us an overview of the current, in terms of the Impact Act that you mentioned, and then also just how, health insurances are treating maintenance therapy. Can you kind of give us an overview of where we're at this day?
Well, we're very early on in the Impact Act, and we're starting to see rollout, and I'm certainly not an expert on it. I still try to work with it. I follow the CMS Innovation Center. That's a great place to go, to go to www.cms, I think it's /innovations.gov. And the idea here is to bring some standardization to post-acute care, post-hospital care. We're seeing that with some of these bundled payment care initiatives, and we're starting to see it with the pilots that are going to be starting with the CJR or the comprehensive joint replacement programs that are mandated in, I think, 67 Medicare service areas, MSAs, across the country. And the challenge is to manage your costs, to incentivize organizations, areas, and participants who provide care to these benefits with cost-effective and good quality and patient satisfaction outcomes. That's what we're looking for. And so the Impact Act is really trying to make sure that Medicare provides consistent care to all geographic and ethnic recipients of the benefit, and to make sure that there's some standardization and cost management. And some of that will come through in some select items and measurements that are going to be used across post-acute continuum or post-acute settings. And some of it is driven by certain models and certain payment incentives and programs that are going to be rolling out, all with the intention to get a handle, to start to control costs associated with the Medicare benefit. Given that almost 9,000 plus or minus people turn 65 every day, where we are right now in 2016.
That's insane.
There has to be some attention given to this. Although you and even I, as one of those baby boomers born in 63, will probably we were not going to see the Medicare benefit as it currently exists. It is still one of the best single payer systems that is out there. but it still needs to be updated, and it needs to be controlled a little bit more and not driven by things such as fee for service. The number of tests the physician refers you to, whether you're going to a physician-owned or a private practice physical therapy, the number of minutes in skilled nursing, the number of visits in home care, moving away from a per visit or per minute or volume type model into a patient acuity model. And so that's where a lot of the drive is going. And we look pretty good in the home care setting with that.
Yeah.
Okay. So I think over the next 2 or 3 years, we're going to see a lot of things start to play out, and it's going to reshape what we're doing or the setting that we're in. But it certainly, I think, it's going to support the advances we've seen in practice and in evidence-based type care, to the extent that I think we're going to be practicing right at the top edge of our profession, if you will.
Yeah.
So now the maintenance thing is kind of a little bit of a conundrum. That's been in the Medicare benefit since the 80s. That's nothing new. We can find references to plateaus and improvement. The improvement standard has never been something that's not a requirement for coverage of services. But it was really brought to light by Judith Stein and the Medicare Advocacy Group, of which Cindy and I, we've talked to her, we met her. She wrote the foreword to our maintenance book, but she brought that to light with a Mrs. Jimmo, who really wasn't a progressive neurological patient. She was a diabetic patient. I think she was on end stage. She was end stage renal, was on a hemo, but she also had an amputation. And she'd get therapy and she'd get home care. And then, these conditions aren't going to resolve. She's not going to spring a new leg like a starfish.
Yeah.
She's not. These things aren't going to happen.
Right.
And she'd get better. And then when she reached that plateau, they discharge and she'd decline. And so she said, I'm entitled to the skilled care. It doesn't matter if I'm going to get better. I'm not going to heal these conditions. And why it's being held out in home care or with therapy is I don't understand it, because if we talk about people that have diabetes and heart failure and COPD and osteoarthritis, they still get seen by nurses. They still go to their doctors for appointments, and they're never getting healed.
Right.
And these services are paid for. So why are we not using our skill set, all the magic that is us, to keep these people functioning optimally in the setting of their choice, which typically is their own home? And so there's a lot of organizations in the post-acute setting that just avoid it. They don't want to get involved in it. But ultimately, as we look at the aging of the population and the frequency and the volume at which we see chronic comorbidities, no matter what you do, you're still going to face somebody who has a problem that is going to exist before you got there. It's going to exist when you're gone. Right. And even though you may have gotten that total knee better, sometimes it's the COPD, the hard of hearing, the early onset dementia, and the systolic and diastolic congestive heart failure that's going to complicate your case more than the total knee rehab ever will. Yeah. And so these are the kind of, this needs to be addressed. We need to embrace it. It speaks to our skill set. Medicare doesn't doubt it. CMS is not saying, prove to us that you're needed. They're saying, just tell us what you're doing to slow that deterioration or decline, reduce those risks of rehospitalization or injury from falls that may result from compromised strength and endurance. And the fact that we're shying away from that and restricting that piece of the benefit to these patients that paid into, these individuals who directly or through spouses have paid into this benefit that they're entitled to, really, I think, goes into a whole nother area of, our ethics and our practice patterns and our standards of practice. Because I don't think it's my right to say, well, you're entitled to it, but I don't do it, so I'm not going to give it to you.
Yeah.
We have to really get away from that and start to say there's a lot I can do, not just to get people better, but there's a lot I can do to keep them from getting worse.
So how do you advise these home healthcare companies that you're working with now in terms of with maintenance therapy? What are some of the things you typically say to them?
Well, first of all, it's really interesting because Cindy Kraft, my business partner, has a really interesting, questionnaire. And it's basically, it's not exactly the ones you'd get out of Glamour magazine or anything, but it's like, are you addicted to progress? Are we as a profession addicted to progress? I mean, look at what we call our visit notes. We call them progress notes.
Yeah.
Have we decided, do we go in and do these one and dones or eval onlys because, we say the person has no rehab potential. Now, wait a minute. Rehab potential is the ability to be responsive to therapy. It doesn't mean that the person has the ability to get better. And so we've tied our skill to people getting better. And so it's our contention that, we kind of do it on the sly anyway. Think about the patient that you feel you have to discharge because they've gotten as good as they're going to get. And what do? We leave them with a program. We tell them to keep doing these things. Mm-hmm. And then if we're in the neighborhood seeing another patient, or we think about them on one day when we're driving around, maybe a song they like comes on the radio or something, we might pick up our phone and we might just check in on them to see how they're doing. Well, that's kind of like, we're doing maintenance, but we're not calling it that, and we're not charging for our services. We're giving away that skill. And so we don't need to hide in the shadows. We don't need to be embarrassed by it. I typically think we automatically think along that continuum as therapists, that it's not just getting a person better, it's keeping them there. It's making sure that, if I come back in 3 months or 6 months or a year, but for unforeseen circumstances, something we couldn't encounter. You had a heart attack, right? You fell, and I don't want to say fall, because sometimes we can, the things we do can prevent some of the contributory factors. But something else happens to you that we can't control. You're going to be doing as well then as you are today, if you continue this level of activity. And that's kind of how we broach it. And as we start to think about it in those terms, people are like, yeah, that makes sense. And many times we see light bulbs go off, and everybody all of a sudden goes, I have a patient in mind. And then we go through those stages of loss and guilt. And then we go, oh no, I should have been doing this all along. What do I do now? And so it's more about just starting to embrace the fact that just because we get people better and we kind of get them to that pinnacle of functioning does not mean that we have to run out of the house, or we have to dump them from the clinic, or kick them out of the facility in post-acute. What it means is that if we believe that there's a likelihood that they could deteriorate or decline without our skilled oversight, then we can monitor them for a period of time and ensure that both the program and their completion of the program is the right fit, so that they're not going to slide backwards. They're going to stay where they are. And sometimes, in my opinion, that takes a whole lot of skill, sometimes as much, if not more, than someone who's recovering, along a protocol from an elective course of care or elective surgery. Sometimes it takes a lot more creativity and thinking and oversight to make sure that all those moving pieces are still working to the benefit of that older adult in their home.
So I know this is going to vary for each patient, but is this something that, like in your experience, would this be a weekly visit, a monthly visit? How? I know it varies tremendously, but I'm just trying to grasp this in my head, because I'm, where I work, maintenance is not necessarily a thing. We're definitely addicted to progress, and it's almost struck, the fear of God in me that if, I overkill my stay with the patient in terms of treating them for too long, then these terrible things are going to happen. And I think most of that is just my ignorance of how, the billing and payment works, in this beautiful system that we have. But yeah, so what would that look like in terms of frequency?
Well, first of all, that's the first response. What does it look like? And a lot of times I'm going to go down the line of it depends. It depends on the patient. Sometimes I see a patient once a month. Sometimes I see him once every couple of weeks. Sometimes I see him once a week. And the only person that can make that decision is you, the clinician. But for you to say, the thing that I want to jump on more than anything is the fact that, it scares you, and you think it's your ignorance. No, the industry has done that. And I don't want to say it's us versus them, but therapists kind of have to take back the night, if you will, or take back the home.
Yes.
We have to know what our license requires. We have to understand the regulatory guidelines that drive payment in the settings we work. In no other setting, it's an enigma to me, do therapists not understand how they get paid,
right,
and not understand how to document to the third-party payers, which is a requirement of our Practice Act. In outpatient, we understand CPT codes. We understand the 8-minute Medicare rule. We understand these things. In hospitals, we know it's the DRG system. We understand how people get paid and what our role is in that place. But why is it in home care we don't bother to read Chapter 7 of the Medicare Benefit Policy Manual and understand the language of how we get paid? And so it's not unusual to have that scare tactic. So because I think, a lot of times we've lacked the accountability, and tell us what you want us to write. Tell us what it is that's going to get us paid. And ultimately, it's what is your skill that no one else can provide to that patient that is indispensable and is being provided according to reasonable standards or evidence-based practice. And that requires clinicians to really think about what they're doing and not just go through the motions from house to house to house.
Yeah.
What a maintenance program looks like, it doesn't look like a person has to get better. The goals aren't written that way. My focus in home care is simply to consistently stay on top of, is this program working? Is it right for the beneficiary? With those intermittent evaluations of the individual, and making sure that when I discharge, that I've provided all the skill that they need, that I have to give them, and I've done everything that I can, not necessarily to get them better, but to slow or prevent what can be slowed or prevented.
Okay.
That's really the focus, and that takes a lot of clinical expertise, and I think we have it. We just don't find a way to get it from our head and the decisions we make about utilization, frequency, and duration down on a piece of paper to explain to a third-party payer, in my clinical opinion.
Yeah.
And that's literally how I write my assessments. It's this therapist's judgment on reassessment that continuation of care under the maintenance benefit would be appropriate because, or based on, and that's what we need to be lending to our documentation, not a whole lot of gobbledygook that doesn't tell us anything.
Yeah.
We have to be very specific to that patient in that setting. Why does this person need to do stair climbing and that one doesn't? Why does this one need to be able to walk 1,500 feet in the community without getting fatigued? But that one only needs to walk 262 feet. That's what we have to start to do, is focus around this patient-centered care plan and answer those kind of questions. And take responsibility for that as therapists, that no one else can make that decision but me. And that's very clearly written in the guidelines that Medicare expects us as rehab professionals to be able to understand when our services are needed and when they're not.
Wow.
And if we understand that, and we understand the language in the Chapter 7, then that's what we write to. And we write in our assessments our professional opinions. And we develop care plans that don't all look like 2-week 9 or 3-week 4 for every patient. They're very individualized to that person. And in that, we start to see a lot of skill jumping off the page because no one else could come up with that.
I appreciate that because for me, I've been out of school for, coming up on like 4.5 years or so. And I am so ignorant to the real world, and definitely in terms of business and then incentives. So when I was in school and definitely out of school, all I'm thinking about is taking care of a person in terms of what in the world do I do with this person in this treatment session, and then just developing plans of care and whatnot. And I feel like I'm just now getting to the point where I'm starting to really look at where are the incentives in our system, for the payers and then the consumer and the therapist as well, and starting to be aware of them and really start to look at how does this stuff work and in terms of the money as well. And home health has definitely been the last place where I've really tried to put that attention. So I appreciate you shining light to that, because you're right. I mean, even in school and clinicals, all about, how an outpatient clinic runs and then the hospital, but, home health, I'm oblivious.
And here's the thing, don't ever lose that. I always worry about the patient. See, that's what we're accused of in home health. They think when we go in, we see the big cartoon dollar signs for eyes every time we see a Medicare beneficiary. And I can tell you to this day, I'll walk in, and I've been practicing for over 30 years, Dustin, and I still walk in and I don't think about it in terms of money. I think about what is it that I can do, what is within the skill set that I can bring to this patient that's going to help them, that's going to make them able to function optimally, reduce the risk for living in their own home as they get older. And so don't lose that. That's the purity of our profession. We want that. But understanding how that works in the bigger picture as far as payment really can help dictate how we document, and to make sure that we're writing smarter, not writing harder. We're writing smarter. We're writing not writing more. We're writing better, and we're writing to what gets us paid, not all this other extraneous stuff.
Yeah, that's beautiful. I appreciate that. That 11 o'clock patient right after this that I was talking to you about is, I mean, she is the prime example of kind of what we're talking about, where she's ready to transition into a maintenance therapy program. And now I feel, so much more comfortable in proposing something that I'm not going to be fearful of down the road.
Well, that's great.
Good.
I've done my job today.
You've done your job. All right. How much do I owe you?
Nothing at all. Nothing at all.
All right. So let's, I want to ask you, I mean, you've been working, for 30, 31 years. You've seen a lot of transitions in PT. You've seen a lot of good and a lot of bad. I want to know, what really makes you an angry person? What really grinds your gears in terms of what you see in home health, but then in just physical therapy in general?
Well, it's hard. When I think about where we're sitting and what I do for a living, some people aren't blessed to have picked something that they've wanted to do since they've been 12 years old. So I am a physical therapist. I don't do physical therapy. I am a physical therapist. So I love what I do. What really gets me is the people that aren't in it for the right reason. And I know that sounds so cavalier.
Yeah.
But when you see these people that only get paid per visit, okay, they're only going to see certain people. They're only going to travel a certain distance in home care. And then they take their wife, who is a PTA that works with them, and maybe 3 or 4 kids on a 2-week Swiss skiing vacation, all off the backs of these Medicare recipients that they document to crap that is not defensible. You stop and realize that there's sycophants. There's bad in every industry. And I don't want us to think that we're the most noblest of professions and there's no evil in us. There are bad clinicians that need to be drummed out. So I'm hoping your wave of new, sexy, young orthopedic sports kind of specialists, DPTs, come in and kick these bad people to the curb, because that's what grinds me. Every time I walk into a house and I do what I consider to be a standard evaluation, it takes between 50 and 70 minutes, just like everybody else's.
Yeah.
But I'm doing a series of objective measures. I'm pulling the tools out of my toolkit. I'm not doing the tug and Tonetti on everybody because that's the only tests I know. I'm pulling out the test that's going to best quantify the impairment in body structure or function that I can link to their activity limitation and show where it's restricting their participation in social roles and responsibilities. And then I'm going to write an individualized patient-centered care plan and use interventions that are evidence-based. But when I walk into the house or I start to do what I consider to be baseline standard care, and a patient looks at me and says, "Can I please have you?" I've had and I say, "Well, you're going to like so-and-so." No one has ever given me this information. No one's ever done this thorough of an assessment. No one's ever did it. And, my chin used to drop, Dustin. It doesn't drop anymore. It angers me because I think that sometimes home health really provides a setting for bad to hide because we're not practicing alongside our peers. There's really no one looking over our shoulder, and we're being held to the standards of practice, the code of ethics of our profession. And when I go in and find that these therapists are just doing these visits, sometimes having them sign, before electronic documentation, 4 and 5 notes and never coming back, and fraudulently submitting these notes, it's obscene. When you talk about preying on the older population, it's terrible. These people sometimes don't even understand the benefit themselves.
Yeah.
And then the second thing that grinds me, this is the next thing, is that when we find out things like this, that we do not report these people's licenses. When we follow people in the home, when we see patients that have been treated this way, that we just say, well, now we'll make it different, but not go back and not be able to track down either those people we work alongside of or call those people out. We don't do our profession. We don't do the industry any justice.
Have you gone through that process yourself in terms of reporting people? Yeah.
Absolutely. I don't like it.
Yeah. How was that experience?
Well, I'm not the only one that's done it. I have some colleagues that work in other states that have. And, it's really tough to get sanctions on a license through their state practice act. But I write complaints. I write complaints, and I've called the ombudsman, and I've called CMS, and I've reported facilities.
Yeah.
The problem is there's not enough people to investigate. That's the problem. And so what we all see is we see the results of what the bad have done. And so instead of taking a scalpel to this, and I'm hoping with technology and being able to track things, they're going to start to focus on bad settings and bad practices. And we see that with the heat task force and the strike force that's set up in Miami-Dade for overutilization. We start to see these things coming to light. But after millions and millions of dollars have been, fraudulently taken from the government on behalf of patients that never received this. So I've done it. I don't think that there's ample enough focused attack on these things, but it's better than it was 5 years ago and tremendously better than it was 10 years ago. In the meantime, instead of that scalpel, it's like they take a machete and they just cut through everything. And they cut through all practices, even the good ones in the industry.
Yeah.
And that to me is a terrible shame. But it's kind of like baby in the bathwater situation. It's the industry we work in. So a lot of people leave. A lot of people say, I'm going to go hide somewhere else. And I think that the people that stay and the people that continue to fight and do things the right way are going to have a positive impact on the industry and hopefully get it back on course and kind of ostracize and get rid of these evil ones, because there's not going to be a place to hide.
Yeah. It was yesterday. I had a initial evaluation. I always ask the person if they've had physical therapy before. And this woman did, and she said, he came for about 15, 20 minutes, and we walked and did some kicks. That was her response.
That sounds pretty typical.
And I mean, I'm kind of like you. I mean, at first I was like, what? Like, really? And now, I expect it. But I am somewhat hopeful as well, especially with technology in terms of, I know it won't necessarily, it'll be tougher to change, I think, the quality of the treatments, but in terms of people just straight up lying, in terms of the signatures and how long they were in the home. Because, I think it's becoming standard, but, the company that I work for, we all get tablets, and, we're all on basically like a 4G network, and it's so easy to track, where you are and when you are, or how long you're in that location. I don't know if they're tracking that right now. They may be without me being aware, but I'm still filling in the subjective, times that I'm in there. And I feel like there is room for lying still, even with this electronic documentation. I feel like that's going to be eliminated very easily, if not already. But
yeah, and not to be like Debbie Downer on the whole situation, but it's kind of a sad testament to our profession that we need to be technologically, monitored. It's kind of like having like the ankle bracelet on if you're on house arrest, It's such a shame, but there are the people that have practiced in such a way. And it's hard because you say, well, why do agencies put up with this? Because there's a dollar sign attached to every visit. And a lot of agencies understand what's going on, but because it's going to affect their cash flow, they just hope they don't get called on it. And that's another shame, because really the only individual or entity or party that suffers for this is the patient, the beneficiary, the person that's entitled to the care.
Right. I agree. So let's move on to your new role as the section president. So, you've been active in the section for quite a while, like you said. But going into your term, what's your vision for your time as president? What do you want to happen?
Well, when I decided to run, I put a little statement of some objectives that I wanted to accomplish. And I'd have to say that I think that those are the overriding issues. I want to make the home health section the go-to resource for anything physical therapy in home care. The National Association of Home Care, the industry, the organizations, CMS should look to us, should look to the APTA and the home health section. And I think my predecessor, Cindy Kraft, has done a great job being that figurehead, being that visible person, not just because she's 6'2", but being
she is tall.
being that person that represents what we are in home care. But I think it goes a little bit further. I mean, I think I'm coming in and not the most technologically sound person, as you know.
You're doing great. You're doing great.
I think we have to start to look at how we can disseminate information quickly to the people that aren't sitting in a clinic location, that don't have all the technology in their hand, but now it's in their car. We have Bluetooth. We have our iPhones. Are we using the Goni app? Are we using the Gate Velocity apps? Are we using the technology that's out there? How can we make products, make resources, make information, and get it disseminated quickly to you through Twitter, through Twitter chats, through I don't want to say Periscope necessarily, but how can we make these things happen and share that with our membership? What other resources do we need? And I'm reaching out for those kind of things now as I sit here and listen to CMS and the Innovation Center, and I look at where we are with CJR starting April 1st in those 67 MSAs, those geographic areas, and I look at all the bundled payments. I'm trying to gather people to the organization that have this expertise, and we do. That's the good news. We have this expertise, and if we don't have it in our section, and we have special populations we need to deal with, those with dementia, those with cancer, those with urinary incontinence, we can go to Sarah Hague at the women's, for the section on women's health. We can go to the oncology section. We can go to other places, and we can still get this information and bring it to our membership. And I think our membership has to be a lot more sensitive to the fact that education needs to be provided in a cost-effective format for a lot of our members who are assistants, who really provide a large amount of care in home health. But I don't know that we've ever really focused our training and our educational offerings for them. So it's about the technology. It's about bringing these experts together. It's about disseminating it quickly, and it's about getting ahead of where we see things going. When we look at the Impact Act, how can we put together talking points for therapists and agencies to go out to hospitals and say, you want to partner with us? Look at our quality outcomes. Look at our patient satisfaction, and look at how we're managing hospitalization. And not just say, hey, you want to join? We're only giving you 4 visits and feel like you're lucky to get it.
Yeah.
Right.
Yeah.
So really to start to, take ownership of what we can do in home care, because we're leaders in every other setting that we work in. And as I look back for when I started 10, 12 years ago, 15 years ago, I was one of the very few agency owners. I was an anomaly. And now, we have chief clinical officers of national, 7th largest privately held companies, in home care. We have regional decision makers. We have largest provider in a metropolitan area is owned. The agency is owned by a physical therapist. We have physical therapists that are vice presidents of home care in privately held equity organizations. We have a huge amount of leadership that I want to tap into, because I feel like once people get to that level, the section doesn't always meet their needs. So we don't want to forget the people that are out in the field. We want to keep providing that information and disseminating it, and using technology and putting good vendors, if you will, good products in front of them to use. But we also want to speak to the leadership and stepping forth and stepping into the light and say, I will lead on this CJR. I'll sit at the table. I'll make the decisions. Don't discount home care and send them right to outpatient. Don't just let it be about the patient preference. Let's stratify the risk. Let's look at, based on these factors, what is the best setting, the most cost effective setting for these people that's going to get you the outcomes, and hopefully in 2 or 3 years when there's incentive sharing, you're going to be well positioned for that. And so that's really what I see my role is as a conduit to the rest of the industry for all that is physical therapy. If you need somebody somewhere in APTA, I'll find it for you. You're out in the industry. I want to bring whatever we have and whatever resources I know about to you so that you can use them most effectively. It's not just about bells and whistles. It's about efficacious treatment. It's about, health literacy. It's about patient engagement, all those things that we're in the prime petri dish, the home, to take care of. And so that's a big challenge for 3 years. But I feel like since I've gotten home from CSM, I've like hit the ground running. I've got people calling me about stuff, and it's just like, I'm a little distractible, Dustin. So
just
like I'll be talking and then I'll go, hey, look at that fat goat over there. I'm off to something else. And so part of it is just tying me down to follow something through. And so, it's kind of like these simultaneous freeways of information going back and forth. But in a nutshell, I'd like to be a conduit. I'd like to be a conduit for all that is physical therapy in the home to the industry. And I'd like to bring all that is available to the therapists working in the home to them in the most encapsulated, easiest way, most cost-effective way to get them the information they need to practice at the highest level of their license.
I can get behind that, and I'm sure many of the listeners can as well. Yeah, it's like you see lots of things happening, for patients, but then ultimately home health. But yeah, I agree with you definitely that there's some disconnect, and there needs to be some continuity and some connections and relationships built to bring all these awesome things that are going on together, to serve, the home health PTs. And like one thing that I'm excited about is, you and Cindy have worked with MedBridge, just the courses that you've done, and just to see MedBridge, which if people aren't familiar with them, they're probably one of the better continuing ed online companies where you can watch really high quality courses. But they're starting to show interest in people like us, the home health PT that's been kind of the black sheep of physical therapy for so long. And just to see that shift, which, for you, it's been a long time coming. For me, I'm just now noticing it. But that's exciting. So I will support you. I know many of the listeners will as well in your fight to improve our setting for sure.
Well, I know because I've always recruited you. I've already recruited you.
You voluntold me, right?
Well, see, that's it, and we shouldn't let that out. Because a lot of people say, "Oh, Dee, you don't volunteer around Dee. You get voluntold." but it's very benevolent, But you have the technology. Sean Hagee with Get PT First, Dr. Carruthers, all these people, Jason Falvey, all these people I sat down with that, but for Twitter I wouldn't have met, but for you, and we look at everything that's going on out there, and we stop and say, I'm gonna recruit you people. I'm gonna get you people to share your expertise because what do they say? Rising water raises all ships. And so I think that there's some people that practice in the recesses of our of our profession and of our setting that can't have they have a smartphone, they have 4G,
right?
But they're not pulling down podcasts. They're not looking at listening to Twitter. They're not doing these audio casts. They're not refilling their cup. And so the way they've practiced is all they've ever known. Right. And I'm not saying that's an excuse. What I'm saying is it's time to rip the Band-Aid off of it and enter the 21st century, jump into the technology, find out where all this information is, and start to have it reflective in our practice. And I think I can do that, or a little part of that, in the next 3 years.
Boom. All right. Well, let's shift gears a little bit. I'm going to ask you some quick questions as we wrap this up.
Okay.
Your responses don't have to be quick by any means, but...
Well, you should have learned they already are.
Oh, boy. So what would you tell your 25-year-old self, knowing what you know now?
I would tell my 25-year-old self not to be afraid to take a position of leadership. I was kind of, I don't want to say you kind of fall into it the longer you're in a setting. It's almost like by tenure. But don't be afraid to step forward and volunteer.
Mm.
There's all the resources, all the support that you need. Don't don't feel like you've got to put in more time and be a better therapist.
Mm.
You know, being a good therapist is one thing, but not all good therapists are good leaders. So if you feel like you need to drive decisioning, then step forward. And a great way to do that in your daily life, in your profession, in your day job, is to volunteer with the section, volunteer with your professional organization, because it will take you light years further than you thought it would.
Yeah.
So that's what I would tell myself. Don't be a passive recipient of what the organization that represents you can offer you. And because everything I've given, I know I've gotten back tenfold from the section, from the APTA.
Yeah.
You know, it's kind of like you get out of it what you put into it.
Yeah. You may have mentioned this. What was that initial event that got you to volunteer or to become active in the home health section?
Starting my own agency.
Okay,
I wanted to get
right,
resources. Yeah, I wanted to get resources. And so, you know, interestingly enough, the first conference I went to was in Boston. And that's where I went to school. I went to Boston University. And so it was nice to go home and hang around, you know, the city that I love. Couldn't afford to live and work in way back then.
Yeah.
So I had to leave the city. It's very expensive to live and work there, even back in the 80s. And the programming had about 5 or 6 sessions, and of which, because of weather, I think, because it's held in February and there was some trouble getting into Logan Airport, like 2 or 3 of them were canceled. And it was disheartening to me. And now I look at where we are now. We had concurrent programming and 2 pre-cons offered this year, and we brought experts from other sections. You know, we've really come a long way.
Wow.
So it was my saying, I'm going to own my own agency. I'm going to, and I did that. Maybe I wasn't 25, Dustin, but I was about, I don't know, 33, 34 when I decided to take that on. And it was a rewarding experience. The hardest work I've ever done, sometimes the most thankless work I've ever done, is being an employer. But the most rewarding, because I knew that I made a difference, and I practiced, and I had people that worked with me that practiced to the standard that I expected.
Awesome. You mentioned that you knew that you wanted to be a physical therapist at the age of 12, I believe. Could you tell me about that?
Oh, that's a personal story. I, like many people, they're exposed to physical therapy early on. And I was 12 years old, the second of now 5 children. And my father, at the age of 39, right after his 39th birthday, within a 12-hour period, was paralyzed, just short of being put on a diaphragm. And they realized that he had like a spinal meningitis type thing that happened to him. You know, he had transverse myelitis. Literally, he came down with transverse myelitis at the age of 39. My mom was 37 and was pregnant with my youngest sister.
Oh, wow.
7 months pregnant with my youngest sister. And my dad went to work one day, and when he came, and he didn't come home. And when I came home from school, I didn't see him for about 3 or 4 weeks, because he was, you know, in the lobster claw splints, and he was at the University of Pennsylvania Hospital Neurological Center, and was told he'd never walk again. And my mom was a nurse, and my mom took great care of him, but he did walk again. He walked with a leg brace and a cane, and he lived. He passed away at the age of 58 when I was like 32. But he did walk, and he did pretty much everything. He never ran. He couldn't run, but he had hand surgery so that he could, you know, he had tendon transplants, things that were done back in the 70s and he came home, and it was phenomenal. Interestingly enough, I would go up to the rehab center with my mom, and I'd see him working with a therapist, and that therapist became my second boss.
Really?
Yeah.
Did
Crazy.
Did that boss remember you?
Oh God, yeah. She knew my dad.
Yeah.
You know, because my dad was in an inpatient rehab, and he was 39 years old, and he was there with a lot of older people that had strokes and things like that.
Yeah.
And so you know, when you grow up with it and you realize I was going to be one of two things. I was either going to be an architect or I was going to be a physical therapist. And I think physical therapists kind of are a little bit architects of the musculoskeletal system. So I kind of think I hit both marks there. When you realize that when you live with it, you realize everything that people can or can't do. You learn really early to listen to the people, to the patient. There was things my dad was never going to be able to do again. I mean, he just couldn't put on his shoes and socks. He couldn't do that, but he could do everything else. And we lived in a 2-story home, and he used to go up and down, to the downstairs modified bathroom. And so not to make it a sob story, but he was a motivation. It's just like if my dad, who literally, they say etiology was unknown. I don't know, but he literally had transverse myelitis. Wow. And it's amazing what he decided he was going to do. Yeah. And he did it. And physical therapy had a huge role in that. Right. Huge role.
I love hearing those stories of just how people get involved in PT or how they're exposed to it. Each person's different. But I do, you do hear a lot of, I was playing sports and I sprained my ankle and I went to PT. And those are great. But I've had a few stories on this podcast that are just, crazy experiences at a super young age. Like, Tim Fox, for example, he shared his story, which was pretty wild as well, of how he got into PT. But yeah, I enjoy that. So thank you for being open with us. I know that's probably not an easy story to tell, but I appreciate it.
Well, I'm proud of it. But yeah, it does bring up emotion, but absolutely love to tell that story. Yeah. Because when I look at older people, I'm like, I've been there. I've lived with someone who's been disabled. I spent, most of my formative years. Right. I mean, with a dad from the age of 12 on who had a disability but was not defined by that. Right. It's huge.
It is. Okay, last question here.
Okay.
Let's say we're at CSM. You have every geriatric rehab clinician in the room. You have their attention for, about a minute. What would you say to them?
I would say we need to have a grassroots advocacy level for our profession and for the industry. What I would say is we need to step up and speak. I don't want to say we need to picket, we need to lobby. What I'd say is we need to get in front of APTA for those funds we put into PAC. I'd say we need to get in front of our congressmen. I'd say we need to advocate for our patients. We need to tell our stories. It's amazing. When they had the open comment period for the final rule for 2016, there was 2 hot button topics, or 2015 on the page. One was the face-to-face encounter. Remember that? Yeah. All the wailing and gnashing of teeth. And then there was the therapy reassessment. They were looking to revise it from, every 13th, 19th, and every 30 days. Yeah. And we said, let's speak to this. They want to hear from us. Let's not assume they're making rules to make our job more difficult. Let's not whine about it. Let's get in and make some comments. Right. And do you know how many comments? Now, there's 12,000 agencies, Dustin. Do you know how many comments were provided to Medicare on the final rule for home health for 2015 out of 12,000? That's just home health agencies. That's not all the employees. That's not all the industry. That's not all the professional organizations like the APTA, et cetera, and the state therapy associations. How many comments do you think they got?
Let's see. I would guess 300.
Oh, that's a lot. They got 100 and they got 118.
Really?
Now, APTA represents thousands of us, right?
Yeah.
Thousands. Man. But it's one comment.
Yeah.
It's one comment. Gosh. And so what happened is these comments came across and they have to address every comment. So we write 1,000 comments about our frontline stories, right? So Kornetti and Kraft, we went on this grassroots that we'll put you in, you'll get a free webinar of ours if you send us what you write to CMS during this open comment period. And we did this campaign. Yeah. And we had people tell their stories, and people were like, oh no, they don't want to hear from me. They want these big organizations, what's my voice matter? Yeah. Interestingly enough, out of those 118 comments, we were kind of concerned, face to face is really going to rule the day. Do you know whether it was face to face or the therapy reassessment that got more comments?
Was it the reassessment?
It was. The reassessment got more comments. And you know who they got comments from? They got people in the field that's saying it doesn't make sense. Because the original plan for the reassessment, getting rid of 13, 19, and every 30th, was to move it to every 14 days.
Oh, God.
Now, exactly. Every therapist groaned.
Yeah.
How is that going to facilitate care?
Right.
Right? And so people wrote stories. And you know what they did? They said, wow, that makes sense. We were trying to help you. And they moved it to 30 days.
Yeah, that was huge, because right when I started, we had the 13th and 19th visit requirement. And those that aren't in home health, say you have a patient that had PT, OT, and speech. Each discipline counted towards that number. So, you would go out as a PT at the 13th visit, do an evaluation, and then maybe within a week, you got to come back for the 19th visit evaluation, or a week or 2 weeks, and just how...
And basically say they haven't had time to make any progress.
Exactly.
This is the one thing. Absolutely. So everybody groaned. So we said, stop groaning and speak up.
Yeah.
Right. So I would say to those geriatric therapists or any therapist that works in home care, know your regulations. And when those comment periods, read them and tell your story, because those stories out of 118 comments, majority had something to say about reassessment.
Yeah.
Produced a response that was desirable. They gave the field what was reasonable. So we have to speak up. We have to know what's going on. We have to speak up, and we have to lead. That's what I would say. I'd say get involved. That doesn't mean you have to be a political. You don't have to stomp on the steps of your congressman. I'm not as good about that. But you have to be a voice, either through your association or through your state professional organization or through a community block. You have to get that information out there, and you have to respond. When they call for an open comment period, tell your story. That's what I would say, because we can make a difference if our voice is heard. We can and bring those patient stories. You know that from CSM. They had a patient panel, and you'd act like that was the most creative thing in the world. In reality, 7 years ago, when we were in, I think it was about 7 years ago, we were in New Orleans, and I'm not minimizing that.
Right.
We had a pre-con on doing tests and measures, and teaching people that we literally got patients to come in, real live older adults that the participants of that pre-con could practice on.
Man.
In the setting that we were. I liaised with local therapists in the New Orleans area.
That's awesome.
And they're members of the organization now, and they're very active in home care. And they have a physical therapy practice where they staff agencies, and they provide home care to agencies that don't employ their own therapists in and around Lake Pontchartrain in New Orleans. And so that's a wonderful, wonderful thing. So that's what I would say. I'd say advocate for your patients, but also speak up and bring your patients with them. It moves mountains.
Yes. And then you would drop the mic on the stage.
Boom, drop the mic.
Awesome. All right. So if people have questions for you or want to learn more about you and what you're doing, and definitely, with Kornetti and Kraft, where can people find you on the interwebs? And I'll include these links in the show notes as well.
Sure. My email address is my last name, Kornetti, Kornetti, at valuebeyondthevisit.com. And our website, Kornetti and Kraft website, is www.valuebeyondthevisit.com. And people can also reach out to me through the home health section. If you want to reach out, you can get on that website at www.homehealthsection.org. Those are great ways to reach me. And my Twitter handle is at my first initial D and last name Kornetti. Or you can do it at Kornetti Kraft.
Yes.
That's the Twitter handle. And I'm not real big on Facebook, I have to tell you. Going back to that attention thing, I like quick and fast. And so Twitter works for me. So those are great ways to reach out to me. And I hope to hear from more people in the section. And I look forward to working with you more, Dustin, and helping to facilitate your senior podcasts and getting you involved in the technological gizmo stuff that we talked about at CSM.
All right. I'm excited. And I want to thank you just for, you're very motivational, and your passion is very infectious as well. Just to hear some excitement around home health is very, refreshing. And just to hear you be very clear and blunt with the problems that we all know exist, but we continue to let them happen. Just to hear you, with your motivation to put that to an end is awesome. So thank you. And yeah, just thanks for your time. Hit me. Thank you for listening to the Senior Rehab Podcast. The show notes for this episode and much, much more can be found at seniorrehabproject.com. If you found value in this conversation, please share this with one other person that could benefit. And until next time, do not forget to stay funky.